Thank you, Noam. Thank you for the committee and thanks to invite me. It's a pleasure to be here. Brief introduction. I'm an orthopedic surgeon. I serve as the head team physician for all sports at the University of Illinois in Chicago. I got to work with the United States Olympic Committee, and I do a variety of knees, shoulders. Used to do hips, but I don't do hip arthroscopy, so I send those over to Ben. We're in the same town. Help me a little bit with the audience before we talk. How many orthopedic surgeons? Fair amount. How many primary care sports doctors? How many physical therapists? So majority physical therapists. And how many performance trainers or actually with the teams? Smaller group. Okay, I think that Noam's goal here is actually to try to see how we all interact. And so some of this is technical from a surgical perspective, but a lot of it is how we're really supposed to work together. And in fact, for all of the teams that I work with, that is all about communication. It's communication of how long it's going to take me. I think, Ben was saying 4 to 6 months or whatever it was. I tell him I don't think the ligament's going to heal for a certain amount of time, and then that's the time frame that the therapist is allowed to go. And then somewhere I know it's safe, then we turn it over, optimizing physical therapy, and then optimizing the return to play. So we'll try to walk through that same kind of a concept, working with the panel, which is a different case. It's all about this communication. So this happens to be a 20-year-old baseball player. Now, I'm cautious when I share this internationally, because internationally some people say they don't really care about baseball. But this is just an overhead thrower. So it could be tennis, javelin, cricket, water polo. Any of those people have the same type of problem. Recent onset of posterior shoulder pain. So this person is throwing, started to develop pain in the posterior aspect of the shoulder, has reduced accuracy. So they're not throwing strikes, or they're not hitting goals. And they have no specific focal pain. They have reduced internal and external rotation. They have a reduced total arc of motion. They really don't have apprehension or instability on examination. And examination of the rotator cuff completely intact on exam. So that's basically the guide that we have. So now with the physical therapist or my orthopedic or my medical colleagues, what's the likely diagnosis? What do we think is going on? What would you do with this guy? Pardon?
MRI.
You want to do an MRI? MRI arthrogram.
I'll do MRI.
MRI arthrogram. Okay, well.
After a good physical examination.
Okay, well, I tried to give you a basic physical examination. He had a really good physical examination, and this is all that we have right now. So we have a thrower who has this reduced performance, no focal pain, little pain posterior. All of my medical doctors, who wants to get an MRI right now? Okay. All of my physical therapists, who wants to go rehab this guy right now? Okay, a lot of people not being very gutsy. So the question then becomes is, what do we really think that he has? So this is just a thrower. He's in early phases. He's not doing so well. He's lost his internal rotation. So he probably has some form of internal impingement. I would agree. He has posterior capsular tightness. He has some type of internal impingement. And so we get our basic x-rays, and I've been instructed by our musculoskeletal radiologist that he's not going to read these because, why, they're basically normal. So most of the time with my athletic athletes, when I get a shoulder x-rays, I'm going to get baseline x-rays. I'm going to get them on everybody because I don't want to miss tumors, weird things. But in all honesty, I don't expect to see much. And so here you see AP on internal external rotation views. Here you see a Y scapular view. And here you see an axillary view. All of which really doesn't show very much in this young elite athlete. So will I screen it? Yes. At this point, now I've done my due diligence. I did my great physical examination. I've gotten basic x-rays. And so this is my big issue. So basically what I think I have right now to start off, I have this guy, I have a thrower, repetitive throwing athlete, and I just told you he had some pain in the posterior aspect. He's lost internal rotation. So they call that GERD, glenohumeral internal rotation deficit. So most of the therapists know that, but we want to look for the issue of the losing internal rotation. My message to you, I know that GERD is the word. GERD is the word, but actually it's not that. It's TR, total arc of motion. So you want to, when you evaluate a thrower, don't just figure out whether they lost their internal rotation. So because you want to see if they've lost their total arc of motion. Because ultimately what happens is when these athletes have thrown forever and ever and ever, they actually reset their shoulder. They reset it in increased external rotation, so their total arc of motion may be normal. But what we want to figure out is did they lose their internal rotation? So this guy did. He lost his internal rotation. So what's the logical next step? What's the logical next step? Rehab. There you go. So this guy wanted to do rehab. So tell me what you would do for rehab for the early athlete. We haven't hit our problem yet, but this is his early presentation.
Okay, so basically two things are missing for me as a physio. First of all, is the symptoms. So how much pain does it, and the pain, how much the amount of pain manifests not only in range of motion deficits, but also in the ability to perform even exercise. So when I want to prescribe exercise, I want to see what he can do at that moment. So for me, symptoms control or hands-on therapy first, maybe modalities, would be a very important thing in order to get an improvement also in range, but also in terms of sometimes the range of motion deficit is only due to pain, and not because he has really significant GERD or whatever deficit, the glenoid deficit that he has. That's for me. Then of course exercise. And exercise is a lot of forms, and that depends on if he is a competitive, let's say for us in Israel, it's usually handball player, but you can have tennis and you can have others. So we want to see what he cannot do in terms of his sport. What is he not able to do? And from that, I will design a rehab program.
And I agree. This is exactly the approach. Most of the time, these guys are presented to me because my athletic trainer or the strength coach has said, or even sometimes the coach has said, he's not throwing strikes anymore. He's weaker. His speed is dropped. And then they send him to me to go, why is that? Because I got a little pain posteriorly, and then we picked this up. And then I communicated with my physical therapist, and he didn't have any pain at rest. He just had pain when he's throwing. So then he goes to the physical therapist to see if he can gain that motion back. And so our problem ends up being this problem of internal impingement. So internal impingement occurs with the arm cocked, particularly overextended. The ball actually, some people have thought there's a little bit of anterior capsular laxity. The ball rides up posteriorly, pinches on the undersurface of the rotator cuff because they're cocked in this external rotator position, and then you can actually damage the superior labrum. So you get undersurface rotator cuff and internal impingement because of this cocked position. So if we actually control that a little bit better, hopefully we reduce future problems. Yes? There's a question.
Sometimes you have a scapular problem that doesn't let you to do the internal rotation. You have to find out what's stopping the internal rotation.
Absolutely.
It can be pain. It can be some problem in the internal rotation. It can be movement in the scapular problem.
Absolutely. So part of this workup may not be completely just the problem inside. We talked about the potential of capsular laxity. We have the potential of actually goes back to my performance guide, so that when I get this guy back, just with this little bit of stretch, we haven't talked about a superior labral lesion, but just with the superior stretch of the rehab, I'm going to sit back and go, physical therapist, what else did we miss? Is it just the rotation? Is my scapular motion intact? Is my core control intact? So then when I'm going to work with my athletic trainer or my strength coach, you're going to sit back and go, is he throwing mechanically properly? Because we all know that throwers, they actually have this kinetic chain, force production from the floor, core rotation to be able to get the ball moving. So all of this is going to be important. So basic things with our physical therapy at this point, this little posterior capsular stretches. Sleeper stretch is probably the first line of treatment, at least for us, in terms of if you truly have posterior capsular tightness, you try to do sleeper stretches. And then clearly, very, very, very important is some type of a core kinetic chain rehabilitation. And so this is my first time, my throwers, we start having a little bit of posterior capsular tightness. And this is courtesy of Ben Kibler. Ben Kibler is the master of scapular dyskinesia. And so you want to figure out, looking from posteriorly, to see if they have any significant abnormality. And you can see this guy, simply by going up and down, starts to wing in his scapula, has scapular problems on this side. And I'll actually assess them Forwards, I'll assess them with their hands on their hips. I'll assess them with their arms out, always trying to figure out whether they have some type of a scapular problem. Actually, this is my free advertisement. If you want to actually do a complete examination, because we don't have time to do that, look up BJSM videos on YouTube. Dr. Hutchinson's shoulder examination comes like in 9 to 12 parts or something like that, and you can see the whole thing. Now, let's go on with our guy, because our guy did this. Okay, our guy did what we just said we were going to do. We thought he just had a little bit of stuff. We didn't get his MRI scan yet, but now we got a problem, maybe because we should have gotten the MRI scan before. So 3 months later, he had continued pain and reduced performance. He had mild improvement in his total arc of motion, so he actually improved with our physical therapist. His exam otherwise wasn't changed, but now he has positive SLAP findings. Now, my orthopedic colleagues, SLAP. What's your favorite examination for a SLAP?
Brian.
O'Brien's. Everybody loves O'Brien's. O'Brien's is this crossover compression test. I like O'Brien's with crossover. Actually, I complement O'Brien's with O'Brien's and then SLAP rehension. So they should painful and then reduction in their pain for a SLAP. Most popular examination probably across the world is an O'Brien's test. Anybody else? Kim test. So Kim, from Korea, he loves this, what we call, actually, it's a biceps provocation. So you put him up in a biceps provocation position, and a Kim 1 is like you walk like an Egyptian, you put your arm out so that the biceps is at rotation, and Kim 2 is resistance to actually pull on the biceps. So you put him in a biceps provoked position, and then that irritates him. I love that examination, and Kim actually says it's more sensitive and specific than O'Brien's test. Anybody else's?
Crank test.
Crank test. So crank test and load and shift test I actually will do, but actually I think they're very non-specific. It may be a label test anywhere, so I think that there's a problem if I crank their arm around or I load their arm and I feel a clunk. I just don't know where it's coming from. So one of the issues with SLAP stuff is it dependable? The problem is if you go look at the literature for SLAP examinations, they're not particularly dependable. And so, and in fact, everywhere else in the world you're going to listen to, they're going to say, don't listen to your exam, don't do this, go ahead and get your MR arthrogram and work with your radiologist. Actually, I'd say that's not necessarily true. So, what I would suggest you do when you look for potential SLAP examination is recreate the mechanical pop. Do Noem's load and shift test. I'm not sure if that's labrum, I'm not sure what that is, but that gets me started. And then I'm going to do each of these. I'm going to do a biceps compression, so O'Brien's and SLAP rehension. I'm going to do a biceps tension test, which is Speed's or Jurgensen's. And I'm going to do a biceps provocation test, which is this Kim test. But I'm actually going to do it special. I'm going to do a moving Mayo shear test. So you start way up high until you find the spot. Oh, that's it. That's my spot that hurts right there. And then you do your Kim 1, your Kim 2, or any other biceps provocation to resist it. I actually believe you can actually do a pretty good exam for SLAP. So if you get positive, positive, positive in each of those, you probably have a SLAP test, SLAP. And in fact, Jed Kuhn has actually suggested to us, although I think that you have a positive examination, he's actually suggested if you can get 2 of those positive, it's time to get an MRI. So he suggests by your clinical examination is your suggestion to get an MRI scan. So kind of interesting. So now we've finally made it to our MRI scan. You want to walk us through our MRI and some findings that you might see here.
So here we have an axial image of the shoulder. This is an MR arthro. In the MR arthro, we inject gadolinium-based fluid material into the joint. And after that, we scan the patient. We can inject it under ultrasound, under fluoroscopy, or blind. Here we have an axial exam. This is the contrast that we injected. This is the biceps, and this is the biceps groove, bicipital groove. We go further down. We are going up here. This is actually here, it is a normal exam. Here we see the posterior labrum, anterior labrum. Here we start seeing a high signal intensity within the labrum, which is not parallel to the glenoid. Here we continue to see this high signal intensity, which is pathologic, which is a slab tear. I will tell about it a little bit later. Here we continue to see the tear here. This is the labrum, the black area, and this is the tear. And here we finish. I will tell a little bit about labral tears and labral anatomy. So the time zone view, here we have the from 1 to 12 o'clock, from 1 to 12 o'clock zones. This is the anterior part, this is the posterior side. Another view, which is the superior, anterior superior, posterior superior, inferior, anterior, and posterior superior, inferior. What I want to say about that, we have not always the labral tears. When we go to check MR images, we have to know about 3 variants that we can see in the labrum. And the 3 variants are sublabral recess, which is a sulcus in the 11 to 3 o'clock area. The other one is labral foramen, and all of these are variants, normal variants. It's not a pathology. So many of the MR images are thought to have a pathology, but actually they are normal variants there. The second one is labral foramen, which is a hole in the labrum in the 1 to 3 o'clock area. And the third one is a Buford complex, which is an absent labrum, which is in the superior labrum. Here we see an example of sublabral recess. Here we see a high signal intensity, which is the issue here, that the signal intensity is parallel to the glenoid. This is the glenoid, the black one, and this is the high signal intensity, the white one, which is parallel to the glenoid, so it's a normal variant, it's not a tear. This is the same patient with axial images. This is the humeral head, the glenoid. And here we see the high signal intensity, which goes parallel to the glenoid here and goes into the glenoid and anteriorly. So it's a normal variant. The second one is the sublabral foramen. Here we see the labrum, the anterior labrum here. We see a high signal intensity between the labrum and the glenoid. Looks like a tear, but it's not a tear. The next image, we see here the labrum, which is intact and normal. So it's a hole here between the labrum and the glenoid, and that's why it's a normal variant. It's not a pathology. The Buford complex is actually an absent labrum. Here we don't have a labrum, and we have a thickened MGHL, the middle glenohumeral ligament. So here we don't have tear in the labrum, but actually we have a normal variant of Buford complex, absent labrum. Actually, labral tears are designed into 10 classes and or grades. Actually, the most common are the first 4 ones, and the commoner one is the second. We will see a few examples here. Here we see grade 1 labral tear, which is slab tear, grade 1 slab tear, which is a fraying of the superior labrum. Here we see the superior labrum. The labrum is the pink or purple color here. This is the biceps tendon, and this is the labrum, which is frayed, irregular, but not teared. Here you can see a supraspinatus tear with retraction here, but the labrum is intact but irregular. second type 2 slab tear. Here we see the tear in orange, which goes into the biceps here, but the biceps is intact. Here we see a signal intensity, high signal intensity, pathologic signal intensity, because it's a globular one and not linear and not parallel to the glenoid here. We see here another labrum area here. So it's pathologic, it's type 2. This is the most common slab injury. The type 3 injury is actually bucket handle injury. It's like the knee, the bucket handle tear in the knee. So it's an injury to the superior labrum with bucket handle tear. And here we see the tear with two high signal intensities here. One is in the labrum, between the labrum and the glenoid. And you can see here a little bit labrum here, which is intact. So it's a tear. It's not a variant. And here we see the second line, which is this one. Okay. So here we have the bucket handle tear. It's type 3. And here we see the type 4 tear, which is a large tear that goes into a bucket handle tear that goes into the biceps tendon. Here we see the tear that goes into the biceps tendon here, enlargement and abnormal signal intensity in the biceps anchor, the biceps insertion here to the labrum, and that's why it's slab type 4. I will not go further
I'll
into.
stop here, and according to this description, the slap injury or the slap tear that the patient of Hutchinson has?
Type 2, slab type 2.
Yeah, so basically, so that's exactly right. So we reviewed those, we got a nice review, and certainly I'm not sure what you guys do. I actually have a weekly radiology conference, and so I communicate directly with my musculoskeletal radiologist, which helps me read them better, because I read them all myself, and helps them get better at their reading once I give them feedback surgically. Question?
I think that it's very important to comment on the yes or no partial thickness tear of the undersurface of the supraspinatus in those conditions. I think it makes a big difference regarding treatment.
Also true, so we want to look at those. So if you have a large, more than 50% involvement of undersurface rotator cuff pathology, you may have to deal with the rotator cuff also. Actually, just so we get to move to the therapy and the rehab part of all this, I'm going to catch you up actually without showing you the rest of my slides, and to tell you that, so who for this baseball player, young athletic thrower, slap 2 tear, wants to do more rehab? Okay, I've got about 6 people who want to do more rehab, because we have a slap tear now, and he already failed 3 or 4 months of rehab, so I got 4 or 5 guys. Who wants to go ahead and do surgery? Okay, that's my surgical colleagues, which is less. By the way, we've been outvoted by the rehab folks. And so I guess the next question is, for those of you who voted, what kind of surgery you want to do? So you're going to do a slap repair? You're going to do a biceps tenotomy? Biceps tenodesis? Now I'm going to quickly tell you that there's a huge debate out in the literature right now. So that in terms of the outcomes of these different things. And so there's a huge trend progressing towards less slap repairs, more biceps tenodesis, even in young throwing athletes, although that's experimental. So mostly what we generally will do is when somebody who's young and athletically active, we try to repair them anatomically, which would be a slap repair. If they're older and maybe have the rotator cuff pathology 40 or 50, then their outcomes certainly are pretty good with biceps tenodesis. Or maybe biceps tenotomy, that's even a flip of a coin. But this guy, ultimately what we ended up doing is we actually did do a primary repair. We did a biceps labral repair arthroscopically with knotless anchors, which is just my favorite way to do it. So now I'm going to throw it back in our rehab folks' lab. I'm done. I'm done. I'm a surgeon now. I'm done. I fixed them, but now you got to start the rehab back to play. So rehab him and hand off to, because he has to play ball, because he's actually one of our starting pitchers for our baseball team.
Just a couple of small things. First of all, I want to go back 1 second, and then I'll go back to the guidelines of rehab, because for us, because we see that conservative treatment fails, and for me, it's a problem. For my patients, it's a problem, and for me, it's a problem, because I will not get other patients. So for me, I want to see why, and to understand why, I need to understand the mechanism of injury for slap, because if I understand why slap occurs, that can explain to me why people with slap doesn't have pain, or why people do get better with rehab and they don't need surgery. Or the most important thing for me would be is that why in the literature that I read for this talk, that I see that sham surgery and normal surgery for slap lesions, basically the results are the same. And that's, for an orthopedic surgeon, it's a disturbing thing to decide to go to surgery with this kind of results in literature.
I
So-
must stop you for a
I'll
second.
go.
Sham surgery.
No, don't. Okay, so a slap lesion is basically a combination of an uncontrolled translation of the humeral head and excessive either compressive or tractional or torsional forces on the biceps. So basically this can help us to understand why some people have a good, they have a positive slap test in one test and in another don't. Sorry, I will try to do it quickly, but English is not my first language. So what we see is that mechanism of injury can, in trauma, you get compression and traction kind of a pull, but in other injuries like the repetitive overhead player to do a lot of the same movement, you can get another mechanism that can reduce the ability of the biceps to do the movement, the cocking position, and the follow-through movement. And you can get other things like the feedback we said, the internal impingement that we said before, but the overhead, for me, the most important thing to say is like the TR maybe changes, and you can have players who is doing a lot of, let's say in handball, because in Israel it's handball usually, you get the players who needs to do a lot in the cocking position, he needs to be further back and do a movement going all the way. So sometimes in order to do that, he wants to throw fast and strong, he's doing some kind of an adaptive things within his body, as Dr. Hutchinson said. And that sometimes can be a problem, sometimes it's not. Why is it a problem and why is it not a problem? Because it's a human being and it's not a drug. And a lot of people have different techniques in the way they throw, and some people sometimes can find another way that he is throwing without having pain, and sometimes not. And this list is basically just a simple list of quantitative factors to show you that we are dealing with humans, and this is why there are differences between people. But anyway, what I found nice, Dr. Hutchinson said, that if you know the mechanism, then you know how to do a slap test that will give you the result that you want. But then if you have a slap test and it's positive, what do you do with it? Because basically, does it really mean something? You can have slap people with slap with no pain, and that's a problem. So, but for our athletes management, what we do usually is, first of all, we get a shoulder pain patient. We don't get a slap patient. And he is pain, and we do the conservative treatment, and it takes time. But the most important thing is not only the medical part that is responsible for the amount of time we have. If it's a 1 week in the season or 1 week before the end of the season, this is completely different. Because in Israel, there is still a thought that if you do surgery, after that you will be okay. So, if it's 1 week before the end of the season, 1 week before the end of the season, maybe it's better to do it because it's going to take us 6 months, between 6 to 9 months to fully rehab a surgical, to do a good post-op rehab. So basically, if it's 1 week within the season, the manager is going to give me time because he don't want the player to lose all the season. Because if he's going to put him in surgery, the player is done for the season. If it's 1 week close to the end of the season, then probably the management is going to demand that he will go quickly to surgery. But this, hopefully, if you have a good doctor in the team and management is cooperating, then probably the medical team can do some can influence. I'll go quickly. Conservative treatment, basically, this is what we mean with conservative treatments. And with the exercise, most important part are biceps, rotator cuff, scapula, and arm, because basically you need to throw the ball to a place in a manner that it's not only about the shoulder. We speak about abdominals and lower extremities. I would like to show some exercises, but never mind. But anyway, in principles of rehabilitation, we need to focus on diagnosis. For us, for physio, is about activity and movement, and not only the tissues involved. And we acknowledge where in the process we are. Where did we find it? Did we find it 4 months after the hamstring, or is it 2 days after the traction pull, but when he was playing and somebody pulled his hand backwards? We emphasize, of course, on functional demands, and we try to do as progression with objective criteria, and we use a lot of different tests, sometimes functional, sometimes self-reported questionnaire, which are good to see because it's a human being and we need to see where he is in the process and not where we are in the process. Progression, of course, in a lot of ways to progress in conservative treatment and in rehabilitation anywhere. So, and then we go back to where the doctor wanted me to start from, and that's the post-op slap type to rehabilitate guidance. So I do not like to. The other slides are basically how do we progress every couple of weeks. But I think that's for physios, it's basic. So I just want to go back to the guidelines. So for us, and of course for me, because some of the doctors are sitting here referring patients to me, and I will also all the time would like to make sure that I'm following what they wanted. They made the surgery and I want to follow them, but if I'm guidelines, then I think about first 3 weeks to 6 weeks, then to 12 weeks to 24, and then going back to sport, which is, for me, the most important thing, because this is where, if I'm a good physio, he's going back and he's not going to return to me. And the return to play is a process, it's not a decision. It's a dilemma and it's a process. And it's a process, and I want to know what do I need to find out at the end of the rehab that the player can do so he will not come back. And the first of all is the ability to perform what is needed in handball. Let's go back to my handball player. And I want to see the ability for him to protect from re-injury while he's playing or practicing. And of course, minimal danger of re-injury and aggravation. And then, in order to get that, we found out in the setting that we are working out is that if he is ready in terms of movement, low intensity, technical demands, and tactical demands, and psychological demands, then he's not going to come. In terms of rehab, I think what we found in an athlete, which is different to somebody or other people in the population, is that basically they need something that others don't. They need not only the maximal strength power, they need the speed. We need to do something which demands ability and accuracy. So quality is the most important thing for us. If somebody is able to do maximal strength in a manner which is not what there's a new term that we found which is nice, explosive neuromusculoskeletal performance, which is quality of movement and quality of performance will get you there without having the players go back to the rehab settings. And we start from down, as you see, this is inside is the wall, the strength training, functional, global, and isolated. Then you incorporate velocity and speed to the rehab, plyometrics, of course, and then you go to the sport specific. And that's, for me, this is the way to go back. You start with an on-field rehabilitation. That means that you're going to take the player, you and Antonio is going to go. On-field rehabilitation means that he's doing the same movements and the same. He performs the same movements he's going to do in the game. But that's on one-on-one. And then he sees that there's no pain and he's able to do it. And then we progress to train. And then in the training, we say to the coach, now there's no contact. There's no contact, and we try to see that how he's doing that. And he's now trying to, again, there is a connection between the eyes and the hand and the coming player that is coming to push you from the side. And he needs to train all that and see how he is able not to get re-injured. So he's kind of going back to training. In the beginning, we say, take time. See that you are okay with that. And he alone is increasing speed. His ability to do quick change of direction or the shoot strongly is with time. Then when we see that he is okay and we speak with him and he says, I'm ready, then we try to do some, what we call a practice game. We take the juniors, we take another team, which is a low-level team, and then we try to let him play. 30 minutes if it's football, 60 minutes if it's handball, then you take 15 to 20 minutes, 45 to 60 minutes until the end of the game. And when he finished a couple of games, a full game, and there's no problem, and he did not have pain, he played offense and he played defense, then I will know that he's going to go back to playing compete with the same level, and then I'm going to give him the most important thing to prevent not to go back to re-injury is that we know that return to performance is not return to play. Return to performance, even if he's back in 6 months practicing, and it took him another month to play, I think only by the end of the next season will you will be able to say that he's back to return to his former performance. And of course, if you take him 6 months away from the game, it's going to take more time to go back to performance than if you take him out of the game for 2 to 3 weeks. Then I think understood. So for me, I don't know if I have time. If not,
I think Antonio will continue.
Yalla. So I'm finished.
And as Antonio comes up, one of the things that I find is that there's communication between everybody. So one of my surgical post-op after a slap repair is, in all honesty, oftentimes I don't send it to physical therapy right away because I'm not exactly sure if I can, forgive me guys, trust you with my patient that I just put some anchors into repair. So I want them to work on early range of motion for maybe about 4 to 6 weeks. But I want them to get the motion back because I want my anchor to stick. If I can trust the physical therapist to say, look, I'm not going to really cock it back and pull out my repair, then I'm going to work with them. So communication will be very important. Then the next phase, once they've done all the stuff in physical therapy, my question is, and I think you're going to hit it, is for my throwing athletes, is who does the throwing protocol? Who does the return to play throwing? Because my physical therapists frequently don't. They'll coach a little bit through it. They'll do some weighted ball work in the physical therapy. But when you get back onto the field, now they sit there and go, what's that progression of actually able to return to play and timing?
So actually, this is the point. From the literature, we don't have anything very clear guidelines. What is the best rehabilitation process for overhead players? We don't have such kind of guidelines. So everything is based on the best practice, daily practice, and experience of professionals working with those players. Another thing we have to consider that actually what happens that we start treating our athletes without getting any information on the status of the player before the injury. So we are just repairing, we are just rehabilitating, we are just considering a scenario that is already biased. The player is injured, we don't know what he used to do before, he doesn't have a let's say called performance passport. We don't know what actually was good and what actually brought him to get injured. So this is, in my opinion, the main point that we have to consider. Just a quick overview. So what I mentioned in the first few sentences that today we don't have guidelines, and actually we have to consider the specificity and the uniqueness of the player once we want to address our process, especially for the assessment. We know that we have a wide range of equipment and devices helping us in, let's say, assessing our players, specifically for the shoulder joint. But the question is if, first of all, this is functional, as was previously said, shoulder is just one chain, the last chain of a very long kinetic link process starting from the ground or from the feet and handing to, let's say, with the head. So assessing just the shoulder in a specific position, in my opinion, this is not the best way. Sometimes we have very highly cost assessment processes by motion analysis, but the accessibility of these let's say systems is not available to all the teams, especially new departments where I work. In my opinion, the next solutions will be field-based assessment with, let's say, easily wearable devices like acceleration-based, where the athlete is not biased to do the specific exercise moves usually do during the game, and ideally would be better to get this information before the injury. So we have to start assessing our players to have, let's say, a very wide information on his capability before the injury, and hopefully to understand what is specifically the mechanism and the process that is leading him to the injury. So just to conclude the presentation, we show you some exercises with a specific handball player, professional handball player. This stage of the rehabilitation process is the late stage, so more or less around, could be matched to the 24 weeks that Ouri previously mentioned, where the player is doing a lot of mostly eccentric overloads by using elastic bands, trying to get back to the full active range of motion.
With core stability.
With core stability, yeah, exactly. With some unstable surfaces, even that this is not the main and the core topic or the main aim. But again, considering the whole body like a unit, considering the demands of the specific sport, considering the functionality of the shoulder. Again, those who are familiar with the handball sport, we know that usually these players are not only involved in throwing activities, especially those players that are playing defense, they have to stop the coming mass, that is not less than 70, 80, 90, or 100 kilos. So they have to deal with the let's say, with mechanical efforts and with a huge variety of movements. Just consider the biomechanics of the shoulder, the degree of freedoms, the combination of movements.
I love the concept that you created in terms of the passport. I mean, I don't think I've heard that word before, but I love the concept of what did the athlete come in with, understanding their passport of health, in terms of did they have a bad mechanic, did they have poor an old injury. All of those things are key to prevent further injuries. One of the things that they've done now in terms of injury prevention over the long time, so this is now we've finally got them back to play and progressed them through a throwing protocol. They're back to play. Are they going to get re-injured? And knowing what their passport is going to be very important. Loading, assessing the total amount of loading to see what their pitch counts were, their total number of throws, gradually progress them back into play is going to be very important for throwers. And then reassessing their kinetic chain as well as their total arc of motion routinely. Chicago White Sox in Chicago, Major League Baseball team, they will routinely, every week, reassess their baseball pitchers. And they lay them down and they reassess their total arc of motion. When they lose internal rotation, they miss a turn in the rotation. They don't get to pitch that next week until they get their motion back. Same thing, they'll do the single leg squats on unstable surfaces. Not as fancy as what you're doing in handball, but doing that same thing as an assessment for their function. They lose function, they miss a rotation to prevent recurrent injuries. I think we should probably wind up. I know we went a little long. I want to thank Antonio and the rest of the panel for